to introduce my colleague in the Department of Health Exercise Science. She might be a familiar face to you if you have been watching the live stream, because she is the face of the cooking team, Associate Professor Stephanie Otto. Thanks, Stephanie.
I am honored and humbled to welcome Dr. Kathryn Schmitz to the 56th Nobel Conference. Dr. Schmitz is one of the leading researchers in the field of exercise oncology. Her work has challenged the medical norms and raised important questions about the role of physical activity in cancer management and treatment. Dr. Schmitz received her bachelor's degree in economics, and out of her passion and interest in dance and physical activity, she went on to receive master's degrees in exercise science and public health and a PhD in kinesiology and exercise science. She currently serves as professor in the Department of Public Health Science at Penn State. Dr. Schmitz is passionate about showing the world the power of physical movement for disease prevention and management. Her most notable work revealed that regular, prescribed resistance training under the supervision of trained exercise specialists did not cause increases in the occurrence in lymphedema among breast cancer survivors. In Dr. Schmitz's most recent work, her team looked at the impact of home-based exercise with or without the combination of weight loss among breast cancer survivors with lymphedema. Dr. Schmitz has served as the president of the American College of Sports Medicine and championed the Moving Through Cancer initiative to help get the word out about the role of physical activity for cancer management. Dr. Schmitz is committed to the integration of science with practice and has helped work to develop the recently released Certified Cancer Exercise Trainer certification through the American College of Sports Medicine. Please help me welcome Dr. Kathryn Schmitz.
Hello, my name is Dr. Kathryn Schmitz. I am a professor at the Penn State College of Medicine. I am speaking to you from our technology-enabled one-button studio, where I'll be giving my lecture. And I would like to thank the conference organizers for their kind invitation to speak with you all today about exercise oncology. I send greetings to my fellow presenters and to audience members who will no doubt create quite a lively discussion for us at the beginning of October. I'll also say a huge thank you to staff member Jared Heitzenrotter, who just started with me in my lab and is forming my audience off camera today. So, all right. I'll also have you note that I have all of my social media handles on my title slide. I am on a mission to try to make exercise standard of care during and after cancer treatment, and use social media as a platform, so I invite you to join me there. So I'll start my talk by giving a historical perspective on issues of exercise and cancer, beginning with the deepest history of understanding cancer from the Edwin Smith papyruses, which describe a bulging tumor of the breast, which was grave and for which there was no treatment. And I start with this in order to underline and underscore the fact that in the history of our understanding of the disease cancer, it's only been relatively recently that we have understood the biology of cancer in a way that it would start to make sense that exercise would play a role for its prevention, in helping with its treatment, and with recovery and survival from cancer. The history of exercise for health goes not quite as far deeply into antiquity. Most people know the Hippocrates quote about exercise and health, but actually the deeper history is from 600 BC, when an Indian physician by the name of Sushruta was quoted as saying, "Exercise makes the body stout, strong, firm, compact, and light, enhanced growth of limbs and muscles, improved digestion and complexion, prevented laziness, and reduced senility." He was indeed prescient, as you'll see from my talk. If we continue on our historic journey, if I focus on the relationship between physical activity or energy balance and cancer from the perspective of epidemiology, we have evidence that goes back over 100 years to Ewing, who described no improvement in cancer with the big improvements that were happening in public health at that time, which related to sanitation. So we had improved sanitation for the public, but what he found was that the people who were heavier, we would say now a higher body mass index, showed no improvement with regard to their risk for cancer. And in fact, he found that the people who ate better and had a higher BMI actually had a higher likelihood of developing cancer. This is still an active hypothesis. We're still interested in the role of energy balance and cancer risk today. In 1921, two University of Minnesota investigators, Silverson and Dahlstrom, uncovered the likelihood of cancer death was inversely associated with the muscular work of a given occupation in a retrospective cohort study. In 1984, we have the first of what might be called the modern era of epidemiology on physical activity and cancer. And this was the first of many, now hundreds, of retrospective cohort studies, case control studies, and prospective cohort studies that link physical inactivity to colon cancer. By 2019, there had been hundreds of observational epidemiologic studies in the literature linking physical inactivity with risk for cancer, as we will review after I'm done with my historical perspective. From a preclinical model perspective, so now we're talking about what we know in antiquity, in history, about the relationship between physical activity and cancer from the animal model. And so in exercise oncology, there is actually a very robust group of investigators that are really interested in understanding mechanisms by which physical activity would have its effects on the development of cancer, treatment of cancer, and prevention of recurrence or survival from cancer. And that work is seen as truly novel. Well, it is, and it is exceedingly important work, but there is also a history to that work. In 1935, Bittner showed that in altering the diet of mice, the age of cancer incidence depended on the physical condition, the amount of wheel running that the mouse did. In 1944, all the way to 1955, there was work happening at the esteemed Wistar Institute in Philadelphia by Rush and Klein. One study showing lower growth of transplanted fibrosarcoma with exercise, with a dose response curve added in. And in 1955, I love this study, Rush set out to do a study to show that induced stress was associated with the increased risk for the development of cancer and cancer death. And so he used forced swimming, physical activity, as his method of inducing stress. And he had what he called a paradoxical effect, which is that there was a lower rate of cancer death among the rats that were forced to do the swimming compared to the sedentary rats. In 1956, Regan showed that exercised mice developed cancer later, lived longer, and importantly, lived longer after a cancer diagnosis. In the realm of clinical trials, what we know is that in 1956, the first thing that I found in the literature was a case comparison from a Dr. Osserman, who showed that several of his multiple myeloma patients that were particularly physically active were doing better with regard to their response to the treatment and their ability to withstand the treatments that were given to them. But the winner of first clinical trials that were done in humans with cancer patients to do randomized controlled trials of exercise goes to the nursing scientist team of Winningham and McVicker. They were at Ohio State University, and what they found in their small randomized trials was that there were benefits for symptoms such as fatigue, and they improved aerobic capacity and body composition even as women were undergoing their chemotherapy treatment. So if we look at the history of the randomized controlled trials in the field of exercise oncology, before we conducted the first American College of Sports Medicine roundtable, what you can see is there's a blue arrow down where everything is very close to the bottom of the slide. And what I'll point out here is that this was a review that was done by Carrie Cornier and Christine Friedenreich in 1996. And what they found was a total of 4 randomized controlled trials, 2 of them from Winningham and Vicker from Ohio State. And they concluded, not surprisingly, that the work was weak and there were too few subjects and more research was needed. So by 2005, we had an increase so that in a meta-analysis that I published in 2005, we found 22 high-quality randomized controlled trials. So definitely there was more work, but there was certainly way more work to do. When I repeated that meta-analysis in 2010, there were 82 randomized controlled trials that were seen to be high quality, but there were even more studies that were not randomized. And so we carried out, at that time, the first ACSM roundtable on exercise and cancer. This was published in 2010 and provided the first evidence-based guidance for exercise for cancer patients and survivors. The American Cancer Society came along 2 years later and agreed with everything that we had to say from the ACSM roundtable. And the following year, the National Comprehensive Cancer Network repeated almost verbatim the words that were used in the ACSM roundtable guidelines, which were that cancer patients and survivors should be physically active, should avoid physical inactivity, should be trying to achieve 150 minutes a week of aerobic activity, and should be trying to do twice weekly resistance training as well. I'll note that when they quoted us nearly verbatim, they did actually quote and give citations to the American Cancer Society and to our paper from 2010 as well. So in the intervening years, in between when we did the first ACSM roundtable and when we have conducted the second ACSM roundtable in 2018, there has been, not exaggerating, an exponential 281% growth in the number of randomized controlled trials in the field of exercise and cancer. As a result, the American College of Sports Medicine saw fit to run an international multidisciplinary roundtable on exercise and cancer prevention and control. This time we decided to do things a little differently because after the first roundtable, while it was great to have that guidance and it was used by people who had already drunk the Kool-Aid, as it were, we didn't have a huge impact on the people who were in front of the patients every day. And so we chose to partner in doing this work with all of the major cancer organizations around the United States, as well as 5 major cancer organizations from outside the United States as well. There were 3 papers that resulted from the ACSM roundtable. The first one was ably led by American Cancer Society researcher Alpa Patel and was really focused primarily on the outcome of cancer itself. Primary prevention of cancer, secondary prevention of cancer, prevention of recurrence and death. And just to give you an idea of the kind of research that existed behind this, I am actually very proud to tell you I can share a few slides from the ACSM roundtable. These were slides that were shared by NCI researcher Steve Moore and are the result of the physical activity collaboration of the NCI cohort consortium. So they basically pulled together 8 North American cohorts and 4 European cohorts into an Uber cohort of 1.44 million participants. More than half of them were women. They were aged on average 50 to 65 years, and there were 187,000 incident cancers in this Uber cohort they did. What they were really looking at was leisure time physical activity. And what we mean by leisure time physical activity is moderate and vigorous intensity, things that you would do in your leisure time purposefully towards the goal of improving your fitness level. So what Moore and company were able to conclude was that there were 13 cancers for which there was sufficient evidence that there was a statistically significant decline in the incidence of these cancers as a result of being adequately physically active. And those relationships held after they adjusted for body mass index. So this was a relationship that was independent of obesity or body mass index. To summarize then what we know about physical activity and cancer survival, so the last slide was about primary prevention. Now I'm going to summarize about physical activity and survival. This slide is directly from the work of Christine Friedreich, who, as a Canadian, was a consultant to the Physical Activity Guidelines Advisory Committee in 2018. And what Christine is able to conclude, along with her colleagues, is that there is really compelling evidence to tell us that there is a reduction of breast cancer, colorectal, and prostate cancer specific cancer death, a reduction of those deaths as a result of being adequately physically active, as well as a reduction in all-cause mortality among people who have had those diagnoses, among those who are most physically active. You can see that there are other disease sites, cancer disease sites, for which there is far less information. So clearly more work is needed in this area in cancer epidemiology. I will say that there are ongoing trials. This is actually a new era. Heretofore, there has been really an assumption that if we were going to try to look at cancer, survival, recurrence, death, as an outcome, that we were going to be looking at observational evidence. But there are 4 intrepid groups of investigators from around the world that are currently doing trials in cancer survivors to look at whether a program of physical activity would reduce the likelihood of death, the likelihood of recurrence of the cancer, and whether we can improve disease-free survival. So this is not a talk about mechanisms. That's not where I've chosen to focus. But I am going to take a second to walk you through this slide about mechanisms and to talk for just a few minutes about the reasons why we think that physical activity could have its effects on the physiology in a way that would alter the likelihood of the development of cancer, the potential for the body to respond well to treatment for cancer, for the body to recover from cancer, and for the body to survive long after cancer. So the mechanisms of action here are all from a review that was in Nature Reviews Cancer from 2017, which I commend to you. And the first thing on the left side of the slide is to show that when you are sedentary, there are changes in the systemic milieu, including metabolic changes, sex steroid hormone changes in inflammation and autonomic dysfunction, that all by themselves are seen to be potential mechanisms through which sedentary behavior would increase the likelihood of the development of a tumor or alter the tumor microenvironment in a way that could alter treatment as well. On the other hand, if we do acute exercise, a single bout of exercise, we know that this changes respiration and cardiac output, glucose output, free fatty acid release in a way that could alter tumor perfusion and oxygen delivery, catecholamines, hypoxia, shear stress. The acute effects of exercise will have an effect on a short-term basis on the tumor microenvironment. Very importantly, in a fit, trained individual, the systemic milieu is altered in the opposite way to being sedentary, in a way that we believe that this is now a resolution of immune homeostasis in a way that alters in a positive way the tumor microenvironment. That is a very indirect path, but in the middle of all of this, understand that repeated bouts of being physically active, of training to do exercise for the purpose of improving your fitness, has alterations in a number of different body systems that result in changed homeostatic control circuits, altering systemic milieu, that same systemic milieu, and thus altering the tumor microenvironment. So what's important to understand, though, is that while I can put up a slide and could have chosen to do 40 minutes of my talk specifically about understanding the mechanisms, this is not unique to cancer. And so it is important to me that this audience understand that there is a second edition of physical activity guidelines for all Americans that are based on the expert review of the scientific evidence of the benefits of physical activity for all Americans, for all human beings, not just Americans, that already has reviewed exactly these same benefits, just not specific to cancer. So for example, this is actually from the UK. The health benefits of physical activity include reduction of dementia. Sustrata was prescient. He told us this in 600 BC. Reduction of hip fractures by 68%. Reduction of depression by 30%. Reduction of breast cancer by 20%. I didn't give you numbers before, a percentage, but these are accurate. Reduction of colon cancer risk by 30%. Type 2 diabetes by 40%. Cardiovascular disease by 35%. And all-cause mortality by 30%. So if exercise could be put into a pill, it would be prescribed to everyone, and everyone would take it every day. And therein lies the challenge. It is not a pill. It is a behavior. It is something that we want people to adopt and take on. And so it doesn't fit into our pill culture of healthcare. It is not as easy for me to get my intervention into the oncology practice as it is for Dr. Carl June to get his CAR T therapy into clinical practice, because there are no pills involved. There's behavioral science involved. It's a completely different way of seeing things. The other thing that I think is important to point out is that it is a different mindset as well, because although the CAR T therapy that you will hear about in Dr. June's lecture, and brilliant work, is extremely specific for a very specific indication and outcome. And so the good news about exercise is that it works for lots of things. The bad news is that then when you try to be very specific about what it is that you're doing with exercise, it doesn't fit into the medical mindset. That mindset says, what is my indication? What am I using it for? And if we say, well, it's good for all of these things, then physicians have a more difficult time kind of wrapping their hands around how they are to prescribe exercise. It is a cultural and philosophical divide. When we conclude at the end of looking at Dr. Patel's work, the American College of Sports Medicine has developed a number of infographics coming out of the ACSM roundtable, and one of them was an infographic specifically about exercise and cancer prevention. And I showed you evidence from Dr. Steve Moore's work, and that was from one meta-analysis. Dr. Patel led a team that looked at all of the available meta-analyses on this topic. And what we are able to conclude on the basis of review of all of the available meta-analyses is that we can say that for all adults, that we can prevent colon cancer, stomach cancer, esophageal cancer, bladder cancer, kidney cancer, endometrial, and breast cancer by asking our citizenry to be more physically active. The second paper that came out of the ACSM roundtable was ably led by Carrie Winterstone and Kristen Campbell. And this paper really addresses what about the symptoms and side effects? What about treatment tolerance? Yes, we care deeply about the diagnosis of cancer, and yes, we care deeply about recurrence and survival after cancer, but people are living their lives as they're going through their cancer treatment and recovering from it. So does exercise have a benefit for these outcomes? The way that Drs. Winterstone and Campbell chose to focus their review for this paper was very much in keeping with what I was just talking about, and that is exercise as a drug. So if we look at exercise specifically, we might want to prescribe it like a drug, meaning we want to know frequency, intensity, time, and type. So for example, if I am going to prescribe chemotherapy, I don't just say, go get some doxorubicin. Nope. Instead, I say, I want you to come in once every 3 weeks. We're going to measure your body surface area. We are going to give you a particular dose of chemotherapy. It is going to take this amount of time for the infusion to occur. It is precise with regard to all of the dosing aspects: frequency, intensity, time, and type. So the question that Drs. Winterstone and Campbell asked the reviewers on this paper to focus on was, what dose of exercise is necessary for specific symptoms, side effects, and treatment tolerance? In order for us to review that evidence, we needed to have some kind of rubric that would help us to decide whether we had sufficient evidence or not. And one of the team members was recently had worked on the Dutch physical activity guidelines and provided us with this sort of tree as a way of deciding whether we had evidence. So the first thing was, were there randomized controlled trials? So if there were randomized controlled trials, we kept going. If there were at least 5 randomized controlled trials, if there was some sizable effect within those trials, if there was no heterogeneity in the direction, then we decided that we were able to write out a fit prescription, and we were able to focus very, very precisely, so that we could tell people, this is the amount of exercise, this is the type of exercise, this is how often you should do the exercise for a given outcome. If we had evidence that was good but not quite at that level, then we called it the moderate level of evidence, and we still gave a fit prescription, but we were a little more circumspect in our recommendations. And then, of course, there were the possibilities of either insufficient evidence, or that we had sufficient evidence and we were quite clear that there was no effect. And so, just to cut right to the chase, because I have a lot to tell you, we were able to draw conclusions of strong evidence and a fit prescription for 6 specific cancer health-related outcomes: symptoms and side effects that people experience as a result of going through cancer treatment, including anxiety and depression, fatigue, health-related quality of life, lymphedema, breast cancer-related lymphedema in particular, and physical function, which is really our ability to get done what we need to get done in our lives physically. So I'll give the example, my mother's ability to carry a case of iced tea into the house from the car. And then moderate intensity, or the moderate level, was bone health and sleep. And then if there are any students of exercise oncology in the audience, there is plenty of fodder for master's and PhD thesis projects. We have a number of outcomes for which we believe that we do not have sufficient evidence to be able to draw any kind of conclusion. So I'm going to go right to telling you what the summary of the guidelines are from this paper. This slide and the next slide are made into one single infographic, and I will give you the link to get to that infographic if you're interested in it. But we were interested in pulling together all of this information in a way that would make it easy for public health professionals, exercise oncology professionals, rehabilitation, oncology rehabilitation professionals, anybody else, patients, to be able to understand in one page what our recommendations are from the most recent ACSM guidelines. So the first set of information is, to get started, avoid inactivity. So what we know from general public health, but also from exercise oncology research, is that getting off the chair, simply moving more, is actually providing benefit. Recall the mechanism slide that I showed. An acute bout of exercise has physiologic benefit that is relevant to the tumor microenvironment. For overall health, the recommendation is to aim to meet the current exercise guidelines for health for all Americans, which is 150 to 300 minutes a week of moderate intensity activity, or 75 to 150 minutes of vigorous intensity activity, plus twice weekly resistance training. But for those 8 cancer health related outcomes for which we are able to give a fit prescription, we have this color-coded infographic that is intended to try to help to describe what it is that you might want to do. So cancer-related fatigue, health-related quality of life, physical function and anxiety and depression, sleep, breast cancer-related lymphedema, and bone health. And what you'll see down here are sort of infographics to help you to understand whether aerobic exercise helps, resistance exercise helps, or whether the combination appears to be helpful as well. So just to give a very specific example, anxiety and depression, which are way over there and over here, are shown as being circles that work in aerobic exercise, but there is insufficient evidence for us to conclude that resistance training by itself is helpful for anxiety and depression during and right after cancer treatment. It doesn't mean it's not helpful, it means we don't have sufficient studies to be able to tell you that it's helpful. And so this is a science and evidence-based set of guidelines. And so this is a summary of all of that information. And very importantly, that infographic is available. It is available on the Exercise is Medicine website. So Exercise is Medicine is an easy phrase to remember. If you simply remember that and go to exercisesmedicine.org, you will find it in the section on moving through cancer. The third paper to come out of the ACSM roundtable was led by yours truly, and is really intended to be about the fact that we have this culture issue. We have a difficulty of translation. We know that exercise is useful for a host of outcomes in the setting of cancer patients and survivors, and yet it is not actually happening. There is this entire ecosystem that needs to be developed as a result of wanting to make exercise be a standard of care element for oncology patients. So there needs to be physician referral. Right now, about 25% of physicians are, anywhere between 9 and 25% of physicians are referring their patients to exercise. There needs to be a customized program, clinically relevant customized program. Well, where are we sending that? Where does that exist? Does that exist in every hamlet of America? It does not. In order for that to occur, there needs to be training for clinically trained exercise oncology professionals who can deliver those programs. There are very few programs in the country that are training master's trained individuals to be able to deliver that kind of quality to our cancer patients. In addition to that, there need to be people who are getting trained to work in your average YMCA, your average 24-hour fitness. They need to understand what they're facing when they're facing a cancer patient. And so there need to be some community-based exercise classes and programs. Exercise delivery to cancer patients needs to have an entire system. There needs to be a whole system of that. In order for us to understand how this is working, we need to have statistics and metrics to understand how people are utilizing this so that we can report back to the physicians and report back to the practitioners, hey, that didn't work so well. Let's try it this way instead. There's health services research here. There's evidence. There's efficacy research. There's implementation science research. There's cost effectiveness research. There's a whole host of things that need to happen for this ecosystem to come into being. Our current state is that about 25% of cancer patients are adequately active. There are a whole host of reasons for this. As I said, they're not getting referred to exercise by their clinicians. And so, big question then, why? Why aren't clinicians talking to their patients about exercise? And the answer is 1, awareness, 2, awareness, and 3, time. So they don't know about it, a lot of them. A lot of them are not understanding, and there is that culture issue that I mentioned before, where physicians are used to prescribing something that is extremely specific. Okay, you have nausea, I'm going to give you this pill for nausea. All right, okay, you have fatigue, I'm going to give you this pill for fatigue. Well, guess what? There is not a pill that is on the market that is better at treating cancer-related fatigue than exercise. It is actually frontline therapy for cancer-related fatigue. So, but even if they had awareness for that, then they would have to say, okay, so their thinking is indication, treatment, indication, treatment. And the whole thinking behind exercise is that, no, exercise is good for what ails you. It's good for everything. So how do we match up these cultures? That's kind of a big question. So we have some educating to do of clinicians, and we have to develop that education in a way that is friendly to those clinicians, that makes those clinicians want to learn more about it. The recommendation from the American College of Sports Medicine Roundtable was that we should be applying the exercise as medicine approach to the setting of oncology. This is something that's already been happening in primary care. So this occurs in 3 different health systems in the United States: Intermountain Health, Kaiser, and Prisma in South Carolina. And in all 3 of these places, when a patient comes in for any kind of therapy whatsoever, whether it's primary care, oncology, cardiology, and orthopedics, anything they're coming in for, there are 2 questions that they are asked that are called the physical activity vital sign. And based on that information, the assessment, the patient is then advised appropriately towards the goal of getting them to become more physically active, and then referred into an appropriate community-based or clinical program according to what the assessment looks like for each patient. This is not foreign territory for oncology from one perspective, and that is that some time ago, cancer centers across America, in order to become accredited by the American College of Surgeons Commission on Cancer, were required to begin to assess psychosocial distress. There is a several question long survey that is used clinically, and there is someone in the cancer oncology, in the clinical team for oncology, whose job it is to address psychosocial distress with every patient who walks through the door at regular intervals. Big quotes around regular intervals. That means something different in different places. But they're already doing it. They're assessing. And once they've assessed, then they give advice and they refer. We're asking only that the same thing happen for a field in which we have over 680 successful randomized controlled trials that show benefit for cancer health-related outcomes from fatigue to lymphedema, to anxiety and depression. We're able to address psychosocial distress with physical activity. So let's actually refer. We've developed something called a prescription pad, which is intended to ease referrals. It makes it easier to go through the assessment and the advice and the referring. But we need to train clinicians to raise their awareness, clarify how easy it can be, document the benefits in the clinic. What we find in places where this has occurred, and it has occurred, there are clinics that have enacted something akin to exercise as medicine in the setting of oncology. And what we find is that nurses who, start talking to their patients about exercise and start assessing, advising, referring, can't stop talking to their patients about this, because what they find is that their patients love it. Their patients actually benefit so much from it, and it is something that they can give their patients that is not chemotherapy, that is something positive for them in their lives. Another issue, of course, is refer where. We've started a registry of exercise programs for people living with and beyond cancer. It's at the same website that I mentioned before for the infographic, so I'll commend that to you. We have started, obviously, an initiative that is under the umbrella of the Exercise as Medicine initiative, and it's called Moving Through Cancer. And there is a task force, an international multidisciplinary task force that has developed a strategic plan and is eager to try to take on the actions necessary to move us from our current state to where exercise will be standard of care in oncology, and our mission is to do so by 2029. I want to finish off by telling you a little bit about what the current implementation status looks like from an international perspective. Who's doing this? Who's actually making this happen? So in the United States, this is largely done by not-for-profit organizations around the country. Livestrong with the Y is the largest one with many locations. Maple Tree Cancer Alliance is another large player in this area. Fit Steps for Life in Texas. Carol Michaels is a household name in New Jersey in this space. There are more, but this is just a smattering of these. But the point is that all of these are not-for-profits that raise money or request funds from health systems in order to run their programs. So they are not-for-profit organizations. They're not charging people for the exercise. So one of the questions is, what is the value proposition for exercise for cancer patients? Will they pay anything for it? And there have been some tests of that, and the answer appears to be a flat no. What's interesting is that they will pay a copay when they go to physical therapy or outpatient rehabilitation, but it doesn't look like there's much willingness to pay even a small amount for exercise. There are certifying bodies, the American College of Sports Medicine and the Cancer Exercise Training Institute, both certify professionals in the United States to prepare them to work with cancer patients and survivors. There are a number of virtual programs that are proliferating around the US, including something called My Victory, which is a commercial entity at this time, and strengthandcourage.org, which is out of Pittsburgh and is a DVD-based program that includes a DVD in Spanish as well as in English, just because that's important to note. To Unstoppable and Fit Steps for Life actually has a whole host of classes that they're offering online as well. But the virtual programs, for the most part, like the live programs, the in-person programs, are largely not-for-profit organizations that are raising money. They are charities to try to get people connected to more exercise. We are currently seeking funding through the Moving Through Cancer initiative to assess the landscape of exercise oncology practice in the United States so that we can better understand the proportion of exercise professionals in the US who are adequately trained to be able to work with cancer patients and survivors, given the fact that as our population ages, the likelihood that the average fitness trainer will run into a cancer survivor goes up. In Germany, there is a very large program at the National Center for Tumor Diseases. The rubric here that is used is that after the person is diagnosed, there are diagnostics that are used to describe what the person needs for exercise, and then they decide whether the person needs counseling and prescription and sent into a public health-oriented network called OncoActive, or do they need on-site exercise or home-based exercise. And for the home-based exercise, sometimes they're just giving them paper, and sometimes they're doing online training. But this is a robust program run by Joachim Wiskman, and they actually are getting a fair percentage of the patients that come through that particular center to go through this process. In Israel, there is a program called Steps for Quality of Life, which is run as a physical therapy-based program, and it is really just quite a remarkable thing to see. It is funded by the Israeli Cancer Society, so again, very similar to the United States. And actually, I should say, in Germany, it is funded by the Cancer Institute. That program is funded by the Cancer Institute. In Israel, this program is delivered by physical therapists. The timing varies by the hospital. It's in nearly all hospitals in Israel. It is often during chemotherapy. I mean literally during chemotherapy. Sometimes separate times from chemo, but often during treatment or after treatment. And you can see yours truly dancing away with Avi, the physical therapist. There are metastatic cancer patients in this picture. There's a broad variety of diagnoses. He basically uses the downtime in between when people have their blood drawn and when they get their infusion started to be able to do a 15-minute session. He brings in music. The music brings in the liveliness, and it was really remarkable to watch him. He went from chemotherapy infusion suite to chemotherapy infusion suite, doing this for about 6 hours, 2 days a week. It is a national program. It's offered in 25 major hospitals. Their annual census, the most recent year I have data for, was nearly 12,000 exercise sessions, including a number of solid and hematologic malignancies, and they're in one pediatric hospital as well. In the Netherlands, there's a history here of what happens to cancer rehabilitation. In 1996, they had this program called Recovery and Balance. They made their first request for reimbursement for basic insurance in 2006, and they were denied. In 2007 and 2008, they had further research that was published in this area. And in 2009, they were denied after their second request for reimbursement. In 2011, they developed a guideline for oncology rehabilitation. In 2015 to 17, they updated that guideline, and there actually is basic insurance, third-party payer coverage for oncology rehabilitation and exercise. But what they consider to be the patient who is eligible for this is like threading a needle. So while they did cover it, they were successful to get insurance coverage for this from their single-party payer insurance program in the Netherlands. What they are able to do is extremely prescribed as a result of the way that they cover things. Finally, in Australia, Australia actually considers their exercise professionals, if they have adequate training, to be accredited, which means they are licensed healthcare professionals, which means that they can provide care and be paid by the single payer program of healthcare in Australia. The downfall here in the setting of oncology is that general practitioners are the ones who have to do the referrals, which means that an oncology patient who wants to see someone who is trained in exercise and cancer has to go to their GP to get the referral, and then they can have 5 sessions a year at what's called the Medicare rate. Cancer patients and survivors are eligible, but it's clunky. So they've done yeoman's work to try to move far ahead of most of the rest of the world, but there's still a clunkiness that needs to be worked out there. So, in summary, there are over 1,000 trials, 680 randomized, but over 1,000 trials in exercise oncology with convincing evidence for primary and secondary prevention for a number of cancers. And there's convincing evidence that exercise is frontline therapy for fatigue and a number of other symptoms. There's certainly room for more, better, more precise scientific evidence. We do need more of those preclinical models to understand the precise mechanisms through which exercise could have its effects on improving response to treatment, on improving recovery from treatment, preventing cancer. But implementation of exercise into cancer care is particularly slow. There are a number of barriers that I've outlined today, including awareness, including cost and reimbursement, including training of oncology clinicians as well as exercise trainers, the healthcare infrastructure and clinic flow, and understanding how to fit the culture of exercise into the culture of treating cancer, and of course, availability of programming. It is my mission in my work to get us to the place where exercise can be standard practice within exercise. And so I thank you very much for listening, and I really cannot wait for our discussions at the beginning of October. Thank you.
999, 1,000. Boy, I'm almost getting tired. How about you, Stephanie? Well, while you all continue your exercise snack, Stephanie and I will have a little conversation. Again, Dr. Schmitz really does, when she goes and gives a talk at a conference, somewhere in the middle of that talk, people are all going to be invited to stand up and do some squats or march in place or something. So really, audience, I invite you to do so. Stephanie, so glad to see you in the studio, our Nobel Lab studio. So let's just get going right away. A reminder, if you would like to submit a question about Dr. Schmitz's talk, that address is pollev.com/Nobel56. Again, that's POLLEV.com/Nobel56. /Nobel56, or you can send it via text to 22333, and you text Nobel 56, and that will let you enter a question. And I'll ask, we'll talk a little bit, and then Stephanie will release the poll and see what our audience thinks about that poll. So what's sticking with you about this talk?
Sure, I think there's a lot. And after speaking with Dr. Schmitz yesterday in the student discussion, she's a very passionate person, and I think some of her excitement and passion for her area is sort of bubbling up in me here this morning. But she, what she said about, if exercise was a pill, every physician would prescribe it and every person would take it. That's sort of it's an interesting thing to say, and it's certainly the cause for many student discussions over the years in the field of exercise physiology. Cause of frustration, those of us that live in this world of exercise physiology, we know and we believe that it works for a lot of different chronic diseases, and sometimes it's frustrating that others either choose not to listen, or maybe they just don't understand. And I know Dr. Schmitz talks a lot about the kind of work that needs to happen around awareness around the power of exercise.
One thing I would observe is that, and now I will begin this by saying I do exercise, but I cannot say that it is my joy in life. So I think one thing is it's so easy comparatively to take a pill. Can you talk about that as an obstacle? That is the whole, the degree to which self-motivation is a challenge here.
Right. So, the first thing I would do, I would sort of argue with you a little bit that I think physical activity is quite easy. If you look at Dr. Schmitz's research and the kinds of exercise that she was using in her studies, they were very straightforward and basic. Nobody was training for the Olympics here. It was, it was the 150 minutes per week, which translates into about 30 minutes, 5 days a week of exercise, and things like what we were just doing, curtsy lunges or march in place or take your dog for a walk. I think what sometimes people, some of the obstacles are they feel like it needs to be hard in order to work. And there's something I think about our human nature that sort of feeds into that idea that it must hurt and it must be difficult in order for me to see some benefit. And that's just absolutely not true. The number one reported barrier to physical activity is time. And there's plenty of evidence and research to suggest that even 10 minutes can demonstrate some benefit. So I really would encourage folks to sort of consider how hard it actually is.
That's a really great way to put it. And I think about how many things are built into my life that I couldn't imagine not doing. Brushing my teeth being a great example, right? And the notion that I don't have 10 minutes to march in place while brushing my teeth, perhaps, is really...
Or recognizing, I know you're a dog lover, recognizing that when you take your dog to the dog park, there's a perfect opportunity, instead of sitting on the bench like we all love to do and watch our dogs, maybe we get up and stroll or throw the ball for the dog, right? That all counts. Mm-hmm.
And while you're doing it, you also clean up the dog park, to civic beautification, right? Yeah. I do love the realization that those little tiny chunks matter, because I think you're right that we often feel like unless we are doing, the Army's get ready for a marathon training program, well, then it doesn't count for anything. So thanks for that encouragement. So she has, earlier Laura and I talked about the fact that during the time of this conference planning, research in this area has exploded. I mean, the number of randomized studies that she says now exist is just gobsmacking. So what do you think we need next? And what is it going to take for it to become a part of just routine in the care and treatment of patients?
Right.
Two separate questions.
Absolutely right. And it's very exciting. And it's also very exciting for, I think, our students, current and future students who may be sort of interested in these areas, particularly in the exercise physiology discipline. I think we're going to continue to see some more specificity around prescriptions, what kind of exercise, how much, how long, how many days a week. We already have a lot of information now that we didn't before, but I think we'll continue to see some more research done related to specific prescription types for specific disease types, right? We'll see some more links there, and I think about the way that we teach students about heart disease in our field, and nobody would argue with you that exercise is an important tool there. I think in the future, more awareness, more education, I think people will suddenly become more comfortable with this idea and they'll believe that physical activity is certainly a powerful tool in cancer management and prevention.
Mm-hmm. In fact, Dr. Schmitz talked earlier in an earlier conversation I had with her. She talked about exactly the case of heart disease and mentioned that when she was trying to present this work about cancer and many clinicians were really objecting, a nurse came up and said, yeah, I remember when this was the response to heart disease. When I was a kid, you were in the hospital flat on your back for a few weeks, and now they've got you not maybe chair or curtsy lunging, but they have you marching around the hall with your IV drip the next day, right?
Exactly. So I think we all, we need to be patient but passionate about this area, about pushing it forward.
That's a great way to put it. So I wonder if you might want to say a little bit for our students in the audience. I know that the Department of Health Exercise Science is really robust at Gustavus, and I'm wondering if you have any thoughts or suggestions for students who are interested in pursuing a career like Dr. Schmitz's. She has an incredible background, which began in economics, included a stint as a dancer with Martha Graham. So there's a lot going on. We probably don't have to do exactly her path in order to become an exercise oncologist, but my sense is this is a growth field. What do you recommend students do?
Absolutely. I'm so glad you asked this question. And I think the field of exercise physiology and this whole conference is just reminding me again of all the different ways that that students can engage with this topic or a variety of topics. And exercise science, it's a subdiscipline of biology. So sometimes we see students in our department who maybe start in more of the hard sciences and then sort of, for whatever reason, sort of find their way to us. And it oftentimes starts off, there's a little bit of a stereotype of the athlete who wants to be the exercise physiology major, but I think that connection is important, and it's deep and it's emotional, and I think that's what makes students really passionate about the field. Is it starts with this sort of love of moving their own bodies and wanting to know more about how they can sort of improve something like sport performance or dance, which I just find it amazing that Dr. Schmitz was a dancer. It makes so much sense to me that she ended up in the exercise physiology discipline. But I think just to continue to be self-aware and recognize what you love about what you're doing, and then find that.
Do you have a picture of what kinds of coursework or what kinds of degree one would pursue in order to? Right, she's saying, look, exercise oncology. I'm putting it on the map. I have a textbook now. It's a real thing. How would I become an exercise oncologist?
Oh, absolutely. Again, I think a basic undergraduate degree in biology or chemistry, biochemistry, exercise physiology, nutrition, all of those areas, behavioral science, psychology. I think there's so many different ways that you could get in. And the other thing I love about what I'm hearing over these last couple of days is that it really does take a team, and it takes a team that have interest and specialties in a lot of different areas. And so those are just a few of the areas that pop to mind.
I'm just noticing, I think that we have a poll that is live. I invite you to go to the poll everywhere, POLLEV.com. And the poll is asking a question about which of the following statements you agree with most. And many of you, like me, will say, well, I agree with a few of them. It turns out that the Poll Everywhere app doesn't allow us to choose all of the above with the complexities that we wanted to. And so we just went with choose one, so we apologize for that. And it looks like I was going to say it's bimodal, but suddenly it's switching up. I feel like I'm watching a horse race. But please do submit your answers to Poll Everywhere, pollev.com/Nobel56. Stephanie, what are some final takeaways if you were going to offer your high-level, this is what matters most about this talk that I heard today? What would they be?
Right. I think there's a couple things. Again, I just cannot emphasize enough how much work there is to be done in the area of awareness. just getting the word out and helping people understand that it works and that it's beneficial, and helping people believe that. Because I think part of the struggle is that people just aren't quite yet there. And I do find it interesting that this particular poll, and maybe I'm getting a little saucy because I was talking to Dr. Schmitz and she's so passionate, but this is the only poll that asks a question about skepticism, right?
Yes.
Like nobody asked, in another poll whether someone was skeptical that immunotherapy worked, right? But in this one, we see the option of being, and I'm so happy to see that the numbers are a little bit lower in that particular category. But again,
Right.
and in a conference related to ethics and access, exercise is free and it's accessible to everybody, even the stairs in your home, and everybody can engage.
That's absolutely right. And I'll just note that, 3% of our audience is, 4% of our audience is skeptical, but almost half of folks are saying more money and research should be dedicated to this. So it sounds like if the public has an opportunity to weigh in, it will become a growth industry. So thanks so much, Stephanie, for joining me for this discussion, and I hope you enjoy the rest of Nobel Conference.
Great, thank you. Nice to see you, Lisa.
Now we turn quickly to our next talk, which is going to be introduced for you by Assistant Professor of Psychological Science and my colleague, Lucy Holmgreen. Lucy.
Psycho-oncologists have taught us that quality cancer care necessarily includes the treatment of social and emotional suffering. Psycho-oncologist Suzanne Chambers has spent her career caring for cancer